So, good afternoon, everybody. Uh, in the next part of clinical differential diagnosis of pain in abdomen, I would like to tell in the last part we have finished with the clinical features when pain of abdomen appears because of the GIT pathologies or where pathologies occur in the intra-abdominal organs. In this part, we would go for the pathologies or the diseases where the pain in abdomen occurs because of other reasons other than GI tract or other than the intra-abdominal organs. The first and foremost of them, of the extra-abdominal part where pain in abdomen occurs, is the genitourinary system. In the genitourinary system, the commonest disease or commonest pathology which is seen in children is the urinary tract infection. Urinary tract infection invariably presents with pain in abdomen and fever and a vomiting like sensation. In case the urinary tract infection is severe, the child may even look toxic. There are associated complaints of burning micturition, but because we are talking of pain in abdomen, we would stick to that part. The pain is typically suprapubic, or it might be, or there might be presence of costovertebral angle tenderness. The costovertebral angle tenderness is generally present when the kidneys are involved, and if it is just the bladder or the lower ureters which are involved, then there might be suprapubic pain. The suprapubic pain is also present in urethral infections. This pain is invariably associated with high grade fever more than 39 degrees centigrade and also vomiting. The vomiting is forceful. In infants, we are going to see the child suffers with lethargy. It is inactive. It does not want to perform its activities. It does not want to move. It is severely irritable. Though consolable, it is severely irritable, and there will be poor feeding, and there will be poor feeding because of vomiting also. The child would refuse feeds because it always has got a sensation of vomiting. In older children, there will be dysuria, that is pain during micturition. There will be increased frequency of urination, and along with the increased frequency, there will be urgency. The child will not be able to hold urine, and therefore many a times um, the parents might complain that the child is passing urine in his clothes, though he has achieved good bladder control. This urgency comes up because of the irritation, and there will be low back pain or in the back pain in the back at the lumbar sides. This is a mild and dull type of pain, and if we go to check the urine physically, there will be a foul smell to the urine. There might be, and that has to be there for the fresh urine. All stagnant urines, this foul smell, but in fresh urine also, with UTI we are going to have foul smell urine. There might be associated hematuria. Hematuria is not a necessary complaint or not a necessary finding, but there might be presence of hematuria because of micro ulcerations which can lead to micro erosions which can lead to bleeding. Now remember, there are urinary tract pathologies where there is pain in abdomen, but if it is whether that is urinary tract infection or no, there is something which we can perform clinically the test, and we can confirm it whether it is a urinary tract infection. To diagnose urinary tract infection, we need to perform a leukocyte esterase and a nitrite test of the urine. These two tests, they give us a confirmatory diagnosis of presence of pus cells, what we call it as WBCs or pus cells in the urine. But this test has to be done within 30 minutes of sample collection, or after that it might give a false negative result, because leukocyte esterase is easily and immediately disintegrated in the urine because of its acidic pH. It gets disintegrated, and therefore leukocyte esterase test and the nitrite test should be performed within 30 minutes. The second one is pyelonephritis, that is the inflammation of the kidney and the renal pelvis. There is non-specific pain in the flanks and the suprapubic area. This pain might be severe or might be dull. It depends upon the uh, magnitude of the infection. Invariably, there is fever. Remember, all urinary tract infection present with fever with chills. So you have to differentiate fever with chills with malaria also, or viral fevers also. But pyelonephritis also presents with fever and chills. There is going to be dysuria and vomiting as in case of urinary tract infection, because that is again a urinary tract infection itself. Thus the difference is this is a supraurinary tract infection. Then the third common disease which appears in children is acute glomerulonephritis. For acute glomerulonephritis, there is non-specific pain in the flanks, or most of the times the pain is in the midline abdomen. The pain in the midline abdomen is diagnostic of glomerulonephritis. If it is in the flanks, you need to differentiate with pyelonephritis, you need to differentiate with renal calculi. But in the midline abdomen, it is specifically in the glomerulonephritis. A typical feature which is present in glomerulonephritis with pain in abdomen is there is oliguria. The amount of urine passed out is much less than the intake, or than the expected one, and this urine is very high color, dark yellow to dark brown color in nature. There might be present, it might be even slightly orange because of presence of RBCs. So it is always a high colored urine, and you will find two specific findings in this disease. There is periorbital edema. This edema is also present in nephrotic syndrome, but the periorbital edema is much lesser in glomerulonephritis as compared to nephrotic syndrome. And there will be, most of the times the child will have hypertension as compared to his, when his BP is checked, and as compared to the age reference BP, he will have a raised systolic blood pressure. So he is going to have hypertension in acute glomerulonephritis. Then nephrolithiasis, that is kidney stones. The stones are impacted in the kidney, not even in the renal pelvis, near the renal pelvis, or in the cortex of the or in the cortex or medulla of the kidney. If it is at the pelvis or near the pelvis, there will be colic abdominal pain uh, in the abdomen or in the flanks. If it is in the flanks, then it is a radiating type of pain. This radiating type of pain is generally seen in ureteric stones also, and that is called as urolithiasis. That is called as ureteric colic. But in nephrolithiasis, there will be colic abdominal pain in the flanks. There there is tenderness which can be which can be seen or examined on palpation at the ipsilateral costovertebral angle. That means the side where there is stone in the kidney, in the same side you are going to feel the tenderness at the costovertebral angle, because the kidneys are retroperitoneal, and in the costal area just below the vertebra. So you will just below the ribs. So you will find costovertebral angle tenderness on the same side. There will be severe nausea and vomiting along with pain in abdomen, and there will be gross or microscopic hematuria which is present over there. When the stone moves, there will be severe bleeding, and therefore there might be gross or microscopic hematuria, and there will be increased frequency and urgency of passage of urine. Then the third one is the torsion testis or ovarian torsion. So in the torsion, the pain or the testicular pain will be of acute onset. There will be an acute onset of testicular pain. The pain from torsion of testicular appendage may develop more gradually and frequently is pinpoint. So initially this pain is, or this pain cannot be pinpointed at the point at the beginning, but in most of the cases, if it is an acute onset, you are going to get immediate acute pain. But if it is a gradual increase, if there is a gradual torsion, the pain will increase slowly. It will be felt on all the sides of the scrotum, and later on it will be felt at one specific point when ischemia on is onset begins. The testis will be tender on touch and it will be seen as edematous. Just see over here, in the case of testicular torsion, it has become inflamed and edematous. The affected testicle may appear higher than the unaffected testicle in a horizontal line. Associated scrotal erythema and edema is seen, as you can see here. There is absent cremastic reflex. The cremastic reflex is a superficial reflex which we see of the muscle, of the cremastic muscle. When you touch it, when you slightly stimulate the cremastic muscle, the testes are retracted. This is known as the cremastic reflex. So this will be absent when there is a torsion of testis. There is no pain relief with elevation of scrotum. If the pain is in the scrotum is because of uh, say a hydrocele or something like, or hernia, and when the scrotum is elevated, and when this elevation occurs, the pain might subside to a certain degree. But in case of torsion testis, this pain does not subside even if you support the scrotum. This pain, the pain in abdomen in testicular torsion is always suprapubic, infraumbilical, and acute type of, and most of the times felt at the symphysis pubis. Acute onset of one-sided lower abdomen or pelvic and tender pelvic mass is seen in ovarian torsion. So similar pain will be seen in ovarian torsion. The ovaries are, in children, are placed in the pelvic girdle. So there will be, when there is torsion of the ovaries, there will be acute onset of the affected side in the lower or the pelvic lower quadrant, or the ipsilateral lower quadrant, or in the pelvic region, and there will be tenderness, severe tenderness, and sometimes you might be able to palpate the pelvic mass. Then in case of ruptured ovarian cysts, there is pain in abdomen, but ruptured ovarian cyst is a typical finding or a typical disease in the puberty or in the post-adolescent stage. So ruptured ovarian cyst should never be diagnosed before in the prepubertal ages. There is history of trauma or sexual intercourse in case of ruptured ovarian cyst. The symptoms usually occur prior to the expected time of ovulation and may mimic ruptured ectopic pregnancy. So when the menses start, generally on the 10th or between the 10th and the 14th day, there is the normal time of ovulation. So in case when there is ruptured ovarian cyst, to in that case you are going to have pain which precedes the release of ovum, and this pain is so severe the patient might go into a vagal shock because of the pain. That pain most of the time is mimicking the ectopic pregnancy. The pain is severe. There is mild chronic lower abdominal discomfort and that may suddenly intensify. When the acute pain subsides, there might be lower abdominal pain. The pain arises because of local peritonitis secondary to hemorrhage. So when the cyst ruptures, the contents of the cyst they go into the peritoneum. The ovaries are intraperitoneal, and when the rupture occurs, the cystic fluid will go and irritate the peritoneum, cause a chemical peritonitis, and that will lead to severe pain. But this peritonitis is localized and not generalized. Peritonism may be present in lower abdomen and pelvis. Peritonism is the signs of similar to peritonitis, but the pathology is not of peritonitis. One, and secondly, only a part of it is involved. So the signs of peritonitis, that is, the signs that we may mimic the peritonitis, that is known as peritonism, will be present in the lower abdomen and the pelvis. And when you go for per vaginal examination, which should not be done in unmarried girls, but in laters, if we can do that, you will find adnexal tenderness. This tenderness is again because of irritation of the peritoneum, and therefore there will be inflammation leading to tenderness. The next disease is the pelvic inflammatory disease. This particularly occurs in young children, and we get a history of sexual abuse to that specific child. After the sexual abuse, this pelvic inflammatory disease may come up in the next 3 or 4 days. So a prehistory of sexual abuse 3 to 4 days prior to the lower pain abdomen will be a suspicion for pelvic inflammatory disease. This disease is very much common in girls who are sexually active. The pain is dull and in the lower abdomen only. It's a continuous pain, a dull pain. There is just a discomfort. The patient keeps on complaining of pain, but he can very well carry out his daily routine. The pain worsens with sexual intercourse. Because it is a pelvic pain, there is inflammation in the pelvis. The pelvic organs a they get the same type of inflammation, and they might also be involved, and the commonest organ to be involved is the bladder, urinary bladder, and therefore dysuria may or may not be present. Most of the times it is present in case of pelvic inflammatory diseases. The the classical feature of pelvic inflammatory disease is there is vaginal or cervical mucopurulent discharge. It is not just plain pain in abdomen or just dysuria. Along with that, the patient will complain that there is some foul smelling mucopurulent discharge from the vagina, and on per vaginal examination, you might even find some discharge from the cervix also. And because there is an inflammatory disease, because there is an infection, the person will have low grade fever. The lady will have low grade fever. Then in case of primary dysmenorrhea, this is seen most of the times during menarche. Primary dysmenorrhea is associated with cramp like pain in the lower abdomen, in the infraumbilical area. You are going to get the cramps, and these cramps, they are associated or they just precede menstruation. They are associated with menstruation or they precede menstruation. Once menstruation stops, cramps will stop. So the history of pain in abdomen with menstruation should arise a suspicion of dysmenorrhea, and you may or may not have lower abdominal tenderness. There are no other systemic findings associated with primary dysmenorrhea. Then going for ectopic pregnancy or complications of pregnancy. We have seen that ectopic pregnancy pain is similar to that of ruptured ovarian cyst. So we need to differentiate it with ruptured ovarian cyst. Like ruptured ovarian cyst, the ectopic pregnancy pain is present only in the reproductive age, in the age between 13 or 14 to the age of 45. In the late menopausal stage, the chances are less, but ectopic pregnancy should never be diagnosed in young children or in the old. So it is present only in the reproductive age, and it is an acute onset lower abdominal pain in the lower lumbar quadrants or in the infraumbilical quadrant. So there will be an acute onset of pain, severe onset of pain. Initially, there will be no abdominal tenderness, but if there is rupture of that pregnancy of the fallopian tube, then there might be severe pain due to peritoneal irritation, and there will be hemodynamic instability. The patient may land up into shock. Once abdominal once the rupture of the pregnancy occurs, once the fallopian are broken down, then there will be moderate to severe vaginal bleeding. And remember, take a history. When you take a history in this reproductive age, never forget to ask the last menstruation. In case of pregnancy complications or in case of ectopic pregnancy, the patient is certainly going to give you a history of missed periods, that is a history of amenorrhea. Now, other than these common genitourinary diseases, we will move on to other diseases where we have pain in abdomen. First, we go to the respiratory system. In the respiratory system, pneumonia and pleurisy, they are the commonest disorders or pathologies seen in children. Pleurisy is a late complication, a complication led to because of pneumonia of any origin, and pneumonia also causes pain in abdomen. In case of pneumonia and pleurisy, abdominal tenderness is present, but because the pathology is in the respiratory system, because it is supraphrenic, you will not feel tenderness in the abdomen. There is no tenderness, there is no guarding, there is no distension of the abdomen. The pain is synchronous with respiration. When you inspire, there will be pain. When you exhale, there will be no pain. The pain will be relieved. So it is always synchronous with respiration. The moment you start inspiring, when you have deep inspiration, there will be pain in abdomen. That is because the intra-abdominal pressure increases, and when you exhale, there will be no pain in the abdomen. This pain in abdomen is associated with the respiratory tract infection symptoms, like there will be cough, there will be coryza, there will be productive cough, the sputum might be purulent, then there might be uh, symptoms of pharyngitis, tonsillitis, because in pneumonia the respiratory area is compromised. There will be shortness of breath. Because of the infection, there will be tachypnea, there will be fever with chills, and splinting will be there secondary to the pain. In case of empyema, abdominal tenderness will be there, and there will be no distension, and there will be no guarding and rebound tenderness, because again this is a respiratory pathology. It is a referred pain because there is increase in the this is a there is a referred pain which is passed on to the abdomen from the thoracic cavity. There will be a history of recent pneumonia which later on has localized to form pus and therefore causing empyema. So empyema will give you a patient with empyema will give you a positive history of the lower respiratory tract infection. The patient will be febrile, the fever will be high grade, say above 39 degrees centigrade, and the patient will have a toxic look. If you percuss the abdomen, you are not going to get any specific finding, but on percussion on the lungs, you will get a dull note. Otherwise, it is always a resonant note if the lung is clear, but in empyema, you are going to get a dull note where there is collection of pus. Where there is collection of pus, you are not going to hear any breath sounds. Like pneumonia, the pain in abdomen will be in synchronization with inspiration and expiration, and there will be cough and chest pain associated with pain in abdomen. So, empyema and pneumonia, they will give you a similar finding. So, in short, if we try to say, then we commonly, then we will be seeing that all GI tract infections have got vomiting. Most of them have got vomiting, diarrhea, and abdominal pain. Genitourinary infections will have fever with chills, vomiting, pain, which is most of the times colicky, and in case of respiratory system, that's a referred pain most of the times associated with respiratory symptoms. The next disease is porphyria. In porphyria, the pain is either in the epigastric region or in the iliac fossa. The pain is typical, it is colicky, and it increases when you have ingested sulfa drugs or if you have ingested barbiturates. It's a typical finding of porphyria. Porphyria is a liver disease uh, which is intolerant to some specific group of medicines. The those medicines are not being able to be metabolized during the first pass metabolism, and therefore there will be toxicity because of that, causing a disease of porphyria. So this pain in abdomen which is present in the epigastrium and in the iliac fossa will precipitate when you ingest barbiturates or sulfas. There will be diffused abdominal tenderness. You cannot localize the tenderness. All parts of the abdomen will be tender and will be accompanied by vomiting, constipation, and fever. This is a metabolic disease. Remember that. Then the another complaint or another disease which comes up is the functional pain. This is very common in children, in generally older children. Females complain more of this pain than males because it is a bit psychological. Typically affects children between 5 to 14 years of age. This pain is episodic or continuous abdominal pain that does not solely occur due to physiological events. Means you cannot relate the pathology of this pain with eating habits or menstruation habits or defecation habits or micturition habits. They are the pain might arise any time of the day, and you cannot correlate it with any of these each and every episode of this pain with any of these habits. The complaint is very vague. The patient might say that it is severe, sometimes it is very dull, sometimes depending upon the situation. The complaint are very vague. Sometimes it's localized, sometimes it is diffuse. This is how the patient will present with, and but it will always say that the pain remains throughout. And most of the times, if you ask the patient to palpate the to pinpoint the site of abdominal pain, there will be the patient will put up its palm on the center of the abdomen, saying that the pain is there in the center of the abdomen. He cannot pinpoint it with a finger, but he will put a whole palm on that area. So the complaint of pain is persistent, vague, and central abdominal pain, mostly at the periumbilical region. And when you try to palpate it, you will show that there is severe pain, which might give us a false understanding of periumbilical tenderness. Functional pain is a chronic complaint. It might recur, or a recurrent complaint, or a cyclic complaint occurring at a various or at a typical cycle. It might or might not be associated with nausea and vomiting. The patient most of the times will forcibly say that he has got nausea, or he might forcibly vomit also. The abdominal examination is generally normal. The abdomen is soft, non-distended, and there is no guarding or rebound tenderness. Other systemic examination, they are normal. There is no abnormal finding or pathological finding of any of the other systems. There is insufficient criteria for irritable bowel syndrome. We have seen in irritable bowel syndrome that there should be a persistent monthly 4 days pathology of some, there should be presence of some symptoms, typical symptoms, for at least 4 days every month. So if those criterias are fulfilled, then we will call it as irritable bowel syndrome. But those criterias are not fulfilled in functional pain, though the patient might say that yes, he has got those similar pains. There will be insufficient criteria for functional dyspepsia or abdominal migraine diagnosis. So functional pain most of the time is a psychological event. Like functional abdominal pain, we have something known as functional dyspepsia. One or more of the following bothersome symptoms on at least 4 days per month should be observed if there is functional dyspepsia. Like irritable bowel syndrome, these symptoms, to diagnose functional dyspepsia, we need to have these symptoms for at least 4 days. What are those? They are epigastric pain or burning in the epigastrium, which is not associated with defecation. After defecation, the burning subsides, or something every time. If the patient says so, it might not be dyspepsia. The epigastric pain should be there, and that there should be burning in the epigastrium. There should be postprandial fullness. After you have your feeds, after the child has his feeds, he should say that he is having a heavy abdomen, and there should be early satiation. The child should feel satiated once he has his food, and that should be early, very fast. Then another disorder is the abdominal migraine. All of the following criteria must be fulfilled for at least 6 months prior to diagnosis, and on at least 2 occasions. So if you have to diagnose a disease called abdominal migraine, you need to follow up a child for at least 6 months. The symptoms should be present. The child must complain of these symptoms from at least 6 months, and the pediatrician should himself uh, be able to examine and find the surety, or make it sure that these symptoms were present in the child at least on 2 examinations within a span of 6 months. The symptoms will contain paroxysmal episodes of severe, intense, acute periumbilical, midline, or diffuse abdominal pain lasting at least 1 hour. The pain in abdominal migraine is generally localized in the periumbilical region, in the midline of the abdomen, and it should be present for at least 1 hour. The patient should have severe pain. He must be feeling uncomfortable, and he should have flexed limbs because of that severe pain. This has to be a cyclic pain. This should come up in episodes, and there should be a reasonable span between the episodes. The span should be somewhere between weeks and months. The pain is incapacitating and interferes with normal activity. The pain is so severe that the child would not be able to handle that pain episode, and he will that pain will hamper his daily activities. The pain is associated in case of abdominal migraine. The pain is associated with two or more of the following symptoms. Anorexia should be present. Anorexia, nausea, vomiting, headache, photophobia. Any of the two or more symptoms should be there when he has pain. So we have to remember that before diagnosing abdominal migraine, the child should have abdominal pain, severe abdominal pain, episodic and cyclic, with a difference between the two episodes of weeks to months. It should be observed for at least 6 months, and the pain should last for at least 1 hour, with severe pain where the child tries to keeps his flex in a legs flexed so that the abdominal muscles are relaxed and the pain subsides. Then we have something known as abdominal epilepsy. Like abdominal pain, like abdominal migraine, we have abdominal epilepsy, and the, there are recurrent sudden attacks of severe pain in case of abdominal epilepsy. But in abdominal migraine, we had seen that the pain was lasting for at least 1 hour, whereas in case of abdominal epilepsy, the pain will last just for a few minutes. So this is the major difference in migraine and abdominal epilepsy. For abdominal migraine, the pain lasts for hours together, whereas in case of epilepsy, it will be short term, very short, because the muscles relax and contract episodically for a short period of time, and then they stop twitching and contracting. So this will be a short time pain. And as we have in grand mal epilepsy, a phase of deep sleep after the episode of epilepsy. Similarly, in case of abdominal epilepsy, this phase of epilepsy is always followed by a phase of sleep. So we need to know that abdominal epilepsy is not of abdominal origin, but something of the neurological origin, always followed by the pain episodes are short and always followed by a phase of sleep. Then there is something known as attention seeking behavior, or we call it as a psychogenic pain of the child. This pain is because or is with the intention to seek attention of the household people, of the parents or the caretakers. The children generally imitate the elders. They have seen what happens when they complain of pain, how people seek attention when they get pain so they seek attention of others when they are when they mimic that, saying that they have pain in abdomen. They have seen some elderly with some typical complaints and they try to mimic them, and therefore they might be able to say that they have severe pain, but they won't give any physical finding with that. This psychogenic pain is most of the time seen in children, smaller children, on Mondays because they don't want to go to the school. So it is also called as Monday morning pain. Friday, Saturdays they are fine, Sundays they are fine, and then with the thought of going to school, they might get pain in abdomen in the Sunday evenings or in the Monday mornings, but just before going to school. In infants, there are some other common causes of abdominal pain other than what we had seen, that infants won't have appendicitis, but they might have Meckel's diverticulum, they might have gastroenteritis, they might have urinary tract infections. they might have torsion testis, all these things. But other than that, there are some other causes for abdominal pain. Those are aerophagy, that is ingestion of air during feeding. So there will be aerophagy, the air will set up in the stomach, that will cause distension of the stomach, and because there is inadequate burping, the air will not be able to escape, and then it will cause pain because of distension. Then there is infantile colic, again because of the same reason, the air is not passed out, and this infantile colic is also known as 3-month colic because this is present up to the age of generally 3 months or 4 months, by when the child starts turning on side and uh, lying in a prone position. Then the gas passes out, and then the pain subsides. So infantile colic or 3-month colic is another cause of pain in abdomen in children, infants. Something known as sickle cell crisis. When sickling occurs, those RBCs which have sickled, they are being transported to the spleen for clearance from the circulatory system, but while getting transported, they might block the end venules and the end arterioles, and that is known as, and that might lead to ischemia, and that is going to give rise to the severe pain in that affected part. This is known as sickle cell crisis. This happens when uh, the sinusoids of the liver or the spleen are blocked, and you will get abdominal pain, and you will also have abdominal pain if you are allergic to some kind of food material like lactose, that is what we call as milk intolerance, or you are allergic to gluten present in the wheat and rye and barley and all those things. So food allergy is common. You might be allergic to egg protein. That might be when the child might be allergic to that, and that might cause abdominal pain. And this is similar to that of the celiac disease, which we had seen in the pain in the as a cause of abdominal pain in from the GI tract. Now going to the Ayurvedic part of the symptom of pain in abdomen. When we speak of Ayurvedic part, we need to know what does Udarshul mean. Udarshul is a part, verbatim translation of pain in abdomen. Udarshul has been explained by Kashyap Samhita in Lakshanadhyay, where Kashyap says that a child should be diagnosed with Udarshul if he has the following signs. He says, स्तनं विदस्यते रौति च उत्तानश्च अवभज्यते उदरस्तब्धता शैत्यं मुखस्वेदश्च शूलिनः. That means a child who is suffering with pain in abdomen, he will refuse breastfeeding. He is not going to have breastfeed. He will refuse all kinds of feed because of pain in abdomen. He will have a continuous cry. It might be consolable, it might be inconsolable. The child will be irritable. He will be keeping on crying continuously. When he falls or when he sleeps in a uttan position, that is on his stomach, when he turns around, he will feel comfortable a bit, and he will better try to keep himself in the same position. He will try to sleep in a uttana position. The abdomen, udarastabdata, the abdomen is slightly distended. It will be without a movement. That means he will try to arrest the movement of the abdomen. The child will try to arrest the movement of the abdomen, and he will lie still in the in a still position, and the child will be having a cold face because of excessive sweating on the face or on the head. So shaityam mukhasvedascha, the child will be feeling a bit cold because of excessive sweating, and he will have excessive sweating of the face also. This has been typically told as a sign of Udarshul, or a group of symptoms which a child will come up with Udarshul. Then pain in abdomen is present in Shula Vyadhi. Now, if we consider Shula Vyadhi, this pain in abdomen is Ashukari. That means it is an acute abdominal onset pain and is felt in the whole of the abdomen. It is present all over the abdomen and it is a continuous type of pain. Satata Shul is present and it is a colicky type of pain or a radiating type of pain. That means it has got Sanchari Vedana. They are not localized, but the child always says, or someone will say, that the pain migrate from one point to other. So this Shula Vyadhi has got a migratory or a radiating or a colicky type of pain. Then something is Parinam Shul. This Parinam Shul is related to your dietary function, your digestive function. This pain will be present when the food is digested completely. When the stomach is empty, you are going to feel the pain. That means typically after gastric emptying, that is typically after 2 to 3 hours once you had your meals. This is a chronic disease. This is a Chirakari Vyadhi, and the pain in abdomen is periumbilical. It is Amashay Asamanta in the periumbilical region. The the pain in abdomen, the pain will typically be present when digestion of the food is complete. That is, it has passed out of the stomach. For further digestion, it has passed into the intestine, but the stomach has become empty. So आहार परिणाम काल में शूल रहेगा. So आहार परिणाम काले शूल is present and आहार सेवन से उपशम मिलता है. That means once the stomach is full, when you ingest food, when you take some diet, the pain will subside. Ajirna and Agnimandya are two other diseases where you are going to get pain. Ajirna is an Ashukari Vyadhi, whereas Agnimandya is a Chirakari Vyadhi, where the food is not, in both the diseases, disorders, the food will not be properly digested or will not be completely digested. The pain is diffused, can be felt in any part of the abdomen. You cannot pinpoint the pain. It is a mild and dull type of pain and it is a continuous pain in the abdomen. It's basically a discomfort in the abdomen because of the mild pain all over the abdomen. The whole of the abdomen is involved in that. There is distension of abdomen, there is adman, what you call it as the distension of abdomen, and because of chardi or because of agnemandya, you are going to have anorexia, no intention of getting food, no intention of eating food, and there will be nausea and vomiting. And if you take a proper history, you are going to see that the child has had continuous eating or had a bad habit of eating or has eaten something which much more in quantity than he can digest. So you have a itihas of adhyashana, continuous eating. Then we have something known as Amlapitta. Amlapitta, again like Agnimandya, is a Chirakari Vyadhi. It's a chronic disorder. The pain in abdomen is moderate to severe. It is rarely dull. Most of the times it is of moderate intensity and it is felt in the whole of the abdomen. The whole of the abdomen will be involved in the pain and it will be felt at any point in the abdomen. It's a continuous type of pain and there will be belching of there will be a sign of a complaint of continuous belching. Now this pain in abdomen will be relieved when the child vomits out, because most of the undigested part will be thrown out and the child will feel relieved of the from the pain when he vomits out. Pain in abdomen is always associated with urodaha, that is burning heart, and udardaha, that is a burning abdomen, and both these symptoms will subside when the child vomits. Then we have another disorder, that is the krumi, that is worms. Again, krumi, they are chirakari. You cannot have an acute onset. They are long standing. The pain is felt in the whole of the abdomen, sampurna udar. There will be episodic pain. Punah punah shul is episodic pain, recurrent pain. And you might have excessive belching. This pain in abdomen is associated with nausea, vomiting, and or diarrhea. Like Amla Pitta, you are going to have a burning heart and a burning abdomen, that is Udardaha and Urodaha, and there will be a typical sign of infestation by the worms, which is typically written by, or which has been typically given by Ayurveda, that is Nasa Kandu, itching at the nose and itching at the anus. Gudakandu and Nasa Kandu, these are typical, or we will call it as cardinal signs, a specific sign of that disease in the children. Then there is another disease known as Grahani, where you ingest the food, but the food is not digested properly. This is again a chronic disorder, a Chirakari Vyadhi. The pain is periumbilical, typically periumbilical, and there is periumbilical tenderness and guarding. Sparsha sahatva rahega, the patient will not allow you or will cry on when you try to palpate the periumbilical region. The pain is continuous, and because of severe pain, the patient will refrain from eating and therefore there will be loss of weight. This is similar to something like in irritable bowel syndrome or functional dyspepsia. And there will be muhurbadha, muhurdrava malapravrutti. Again similar to something like of Crohn's disease, that the child passes loose stools in the sometimes it might be properly formed stools, sometimes the child might be constipated. So in such case we need to understand that this is typical finding which we can also see in Crohn's disease. Then we have Purishaj Adhova or Adhovataj Udavarta. Udavarta is a change in the direction of the Vayu, in the normal direction of the Vayu. So the अपान वायु has a downward direction, अधो दिशा होती है. So in पुरीशज और अधोवातज उदावर्त, the अपान vayu turns its own direction up in the opposite direction. That means what it should have a direction of throwing the things out of the body towards the ground, towards outside, it instead turns upside down and tries to hold on all those things which need to be thrown out. So this Udavarta is Ashukari. It is an acute type of disorder and it might affect the whole of the abdomen. The pain is severe, the pain is continuous, and it cannot be located, pinpointed out. It's a continuous severe pain. There will be abdominal distension. The abdomen on percussion will be tympanic, and because one vayu is affected, all other vayus are going to get vitiated and there will be again shirashul in Purishaj and Adhovataj udavarta. Then another Vyadhi, probably the last one, that is the Gulma Vyadhi. Gulma is collection of the doshas in five, any of the five spaces in the abdomen, that is the uterus, the flanks, the intestine, and the hypochondria. This Gulma Vyadhi is a Chirakari Vyadhi. It's a chronic disorder. It comes up after a long time of pathogenesis. You have pain either in the bladder, basti, or in the infraumbilical region and into the flanks, parshva mein, shul rahega. And this pain is moderate to severe, and it's a continuous type of pain. This pain is again radiating type of pain. The Gulma in Ayurveda, in Charak Samhita, Gulma has been said to be a motile entity. It keeps on moving. So as the Gulma moves, as the collection moves, there will be pain. And this movement is generally in the infraumbilical area, that is the Basti Pradesh, or in the Parshva, that is in the flanks. Then we have something known as vidradhis, that is abscesses. Abscesses are acute infections and they come up suddenly. So it is a Ashukari type of Vyadhi. The pain will be at the site of abscess. We have so many abscesses which have been told in Ayurveda. There are 9 spaces where you get abscesses. For that, pain in abdomen is present with uh, abscess in the liver, yakrut, pliha, spleen, vrukka, fufusau. These places have been said to contain abscess in Ayurveda also. The pain in abdomen will be at the specific site of the abscess. There will be tenderness and guarding. The pain is continuous and a throbbing type of pain. Initially, it will be pulsating and then it will be a throbbing type of pain, and the patient will have a toxic look. There will be severe grade fever, high grade fever, generally above 39 degrees centigrade. The site above the abscess will be inflamed, it will appear red, and there will be severe tenderness. So in short, if we try to find out what, or we try to collect the symptoms system wise, then we will say that pain in abdomen when associated with GI tract is most of the times associated with the pain will be present along with vomiting and or diarrhea, nausea, and gastric discomfort. This is when the pain in abdomen is because of the pathologies of the GI tract. If it is because of respiratory system, the pain is referred because of the respiratory system, it will be the associated with cough, coryza, signs and symptoms of pharyngitis, laryngitis, pneumonitis. There will be shortness of breath, and this pain in uh, pain in abdomen will be synchronous with the respiration, and this is a referred kind of pain. If the pain in abdomen is because of the genitourinary system, in case of urinary case, you will have the pain in abdomen with dysuria or high colored urine or painful micturition or hematuria, and most of the times a colicky pain which is radiating. If it is because of the genital system, the reproductive system, then it will most of the times be a acute pain of acute onset of acute origin and may be present with signs of peritonitis or what we call it as peritonism, and will be inconsolable. In other parts where the neurological system is involved or the limbic system is involved, the pain needs is very typical to that specific disease. So I think I have cleared up with most of the points of pain in abdomen, modern and Ayurveda also. Thank you.